recording going.
It's 10:31, so we're going to go ahead and get started, and then Nicole will click Zoom. I see people are just continuing to jump on. I've been going to NACDEP since 2006, I think, or 2005, and yeah, this is a little different this year. And Nicole and I are excited to kick things off. We know that there's 4 other presentations going on at the same time, and we appreciate you choosing to or electing to attend this one. So without further ado, we have plenty to cover today in the next 90 minutes, and so we'll go ahead and get started. My name is Michael Wilcox. I'm the Assistant Director and Program Leader for Purdue Extension's Community Development Program. And while it says I'm lead presenter, really Dr. Nicole Adams is the lead presenter and the brains behind what's going to be presented today. I just wanted to quickly give a shout out to Nicole. I've had the pleasure of working with her and with Aaron Belgard, who's also on the presentation today, for the last 6 months now, 7 months on the Turtle Mountain Band of Chippewa reservation up in North Dakota, Belcourt, North Dakota. And Nicole's been doing this work for a long time, but this has sort of all come together, community development and the School of Nursing coming together and working on recovery-oriented systems of care and exploring how community development and ROSCs kind of come together. So Nicole's going to take us through hopefully an exciting 90-minute adventure today. If you have questions, I'll be monitoring the chat. And Jill Hawkinson's also from North Dakota, from USDA Rural Development. She's been working with us on the READY program. So if you have questions, please put them in the chat, and Nicole and I will try to get to them in a timely manner, either during the presentation, or if we can, we'll leave some time at the end of the presentation. So without further ado, Nicole, go ahead and kick us off.
Thank you, Michael. I just want to make sure, just a nod of heads or thumbs up, everyone can see the title slide, the intersection of community development. Perfect. I want to make sure that that's going before I get 4 slides deep. So today we're going to be talking about how community development and really complements and works together in developing a recovery-oriented system of care and what that is. And so the focus today is on substance use and how that impacts communities and what the community can do to address it. So my primary area of research is how community coalitions address substance use and what makes them successful. So first, we're going to start off with that poll. So if you did not do it already, you can either text to the number 37607, and in the message put Nicole Adams 580. Or if you're on a computer and want to open a new browser window, you can also go to pollev.com/Nicole Adams 580. So this is just going to be a quick poll. Once you do that text, you get a welcome message, and then you can just enter one of the letters. So think about someone you know that's struggling or has struggled with substance use, and who is that first person that you thought of? So I'm going to give a little more time for a few more responses. All right, so as we can see, everybody knows someone, and sometimes it's someone really close to you, and sometimes it's someone that you work with and their son or daughter or husband or wife. And as we move forward today, I want you to keep that person, picture that person that you know as we move forward and we go through a few of these slides. So let's talk about substance use first. This includes illicit drugs, alcohol, misusing prescriptions. The impacts of substance use are felt throughout the community on many levels. It affects health, it can affect relationships, children. It definitely affects crime rates. Prosperity of the community as a whole can be impacted, and employers can also feel the impacts of substance use in their community. In the 2018 National Survey on Drug Use and Health, it was estimated almost 20%, 19.4% of the population over 12 used an illicit drug in the past year. That's 53.2 million people in the US. That's a lot. I mean, that touches every community. There can be a lot of barriers when you're trying to address substance use in rural areas, which a lot of these people do live in rural areas. And so how do we kind of focus in on those? So a little more information about substance use disorder. So it's what we it's a medicalized term for addiction. It comes from the DSM-5, which is the Diagnostic Manual for Mental Illness and substance use is included in that. There are 11 criteria in 4 different categories. The first is impaired control, and the criteria fall into these 4 main categories. So impaired control, for instance, you can't stop using and it changes your, and you keep seeking it. Social impairment, so that's, affecting your relationships, affecting your work. Risky use, so pushing the limits, taking more than you should, knowing it could be hazardous for you. And then the pharmacologic indicators like a tolerance, or if you stop, you begin to withdraw. So that they use those 11 criteria in those 4 categories to determine if you are mild, moderate, or severe, and that's the clinical medical portion of substance use. But there are underlying risk factors that can cause people to be at higher risk for developing a substance use disorder. The most common are depression, anxiety, and adverse childhood events, or ACEs. So these can be either physical or emotional traumas that happen to people as children. They can also be another cause of substance use disorder could be a physical or emotional trauma in adulthood that then leads to that. So now think back to those people that you thought of in that poll, someone you know with substance use. Do you know which of these risk factors they may have had or may have? It may not be obvious. Anxiety is kind of like the sleeper risk factor. A lot of people have anxiety and don't know, but yet when they start using substances, they feel better because their anxiety is at bay. So we want to talk a little more about trauma because that's huge. Those adverse childhood events are huge drivers of substance use. So there's 3 E's when we describe trauma. One is the actual event. One is the experience. So some people have an event, but they don't have the experience, that personal response to the event that makes it a trauma to them. But having those feelings, it can include things like shame, helplessness, guilt. If there's a trauma where one person dies and the other lives, they may carry that guilt with them, which is a huge experience piece. And then the effect. So does this effect cause a long-lasting effect, or is this something that someone can move past quickly? So we want to use the trauma-informed approach when we talk about how we address substance use. So we first make 4 key assumptions, the 4 R's. Realization. So everyone in the organization, everyone in the community collaborative or coalition, everyone who's working on this topic needs to make a realization, have that realization and acceptance that trauma is real and that it's not made up and it is a real influencer in this. Recognition. So everyone knows how to recognize those symptoms of trauma. Response. So the response of the organization using the 6 principles, which I'll go into on the next slide. And then resisting re-traumatization. So that's designing treatments, that's designing environments. This can be either clinical or community that do not re-traumatize victims. So my favorite example of this that I heard was a VA hospital where they had a lot of female vets coming in for treatment for recovering from sexual assault that they experienced while in military service. However, the door to their treatment center, to get to the door, they had to walk by the smoke shack where there were always 10 or 20 men smoking. And so they had to walk by this row of sitting men as they went into treatment for sexual assault. And that was re-traumatizing a lot of the women, having to walk past this line of men. So that is not a trauma-informed approach. So that kind of resisting re-traumatization, you really have to think about where you could have that happen. So the 6 key principles are also incorporated. So one is safety. So you want both physical and emotional safety to be at the forefront. Trustworthiness and transparency at all the organization and leadership levels. There's no secrecy, there's no hiding what the agendas are. Peer support, having people who have shared lived experiences to say, yes, you can do this too, is very, very powerful. Collaboration and mutuality, partnering to level control. That also goes into the next one, empowerment, voice, and choice of the shared decision making. So it's not just a treatment provider or a clinician telling someone what to do, but they're making the decisions of what path to take together. And then making sure that cultural, historical, and gender issues are acknowledged and addressed and approached in a respectful manner. So as Michael had said, we have been working in North Dakota with the Turtle Mountain tribe. And so there's a few other considerations when you're trying to provide trauma-informed care in Native American communities. So one, the historical sources of trauma are very real, and the effects of those historical traumas are still impacting tribal members today. So those historical traumas include boarding schools, where people were not, it wasn't a voluntary thing, it was an involuntary removal of children and sending them away to school. It was the loss and theft of their ancestral lands. It's the imposition of a dominant cultural lifestyle. So replacing their cultural lifestyle with our own lifestyle, the American lifestyle. So there are also modern sources of trauma. So violence at home. And so what's really ironic in this is that boarding schools may offer a safe haven today, whereas they caused historical trauma in the past. They may be a way out for children to avoid violence at home today. Substance use at home, parents in jail, parents dying due to an overdose or a violent crime, and sexual abuse. Those are adverse childhood events that contribute to modern sources of trauma. We also have physical traumas such as sexual assault, motor vehicle accidents, injuries from other activities. These things also can compound the historical trauma as modern sources that lead to substance use. So to be successful in recovery from substance use disorder, people must recover from these traumas and or their underlying mental health conditions, that depression, that anxiety, in order to be able to have the tools to be successful. So also in Native communities, there is a concept called well-briety. This was developed by Don Coyas. He is a Native American Mohican Nation member who runs an organization called White Bison. And if you're interested in learning more, their website is herewhitebison.org. But well-briety means both sober and well. So it's not just sobriety, you have to have wellness, healing and balance, not just physical, but mental wellness, spiritual wellness, cultural wellness. He uses the analogy of the sick tree. If you take a sick tree out of the forest and you plant it in good, healthy soil and bring it back to health, but then you plant it back into the poor soil it came from, you should not expect that tree to do well. It will become sick again. So in this, it kind of talks of, so in this analogy, he's referring to healing more than just getting sober, but you have to heal the soil around the person, and you have to build up their own stamina and also help heal the community around them. Part of the important work in this is reclaiming culture. So having that strong cultural foundation for Native Americans provides strength for the hard work of recovering from substance use disorder. And it means returning to traditions, but not necessarily pushing away from contemporary life, but learning how to blend tradition with contemporary life. And when the community does this, it provides strength and resiliency for youth, which equals prevention, which is the most effective way to address substance use, is through prevention. So we're going to do another poll. If you've joined us late, you can either open a browser, pollev.com/NicoleAdams580, all one word, or text to the number 37607, NicoleAdams580, all one word, and to join our poll. So now what you want to do is, if you've already joined previously, you don't need to do that again. You just enter the words, the first words you think of when you hear recovery. So I'll give everybody a couple minutes to get those in, and then I'll go ahead and move to the next slide and see what that looks like. All right. All right, so we can look at our word cloud. We can see the words substance use disorder, SUD, and struggle came up more than other things. It is a struggle. Recovery is hard work. But there's also hope. Hope just popped up more. Hope is a huge component in this as well. And we're going to talk about that here on the next slide. So first, we're going to talk about the words we use when we talk about recovery. Don Coyes says, our words are important. If you want to care for something, you call it a flower. But if you want to kill something, you call it a weed. That's extraordinarily important to keep in mind, that the words we use when we're working with people with substance use disorder can impact how they perceive whether we're trying to be helpful or we're trying to be harmful. So substance use disorder is the term we use in place of addiction. And because it kind of makes it more of a disease rather than a lifestyle choice, which we now know that it is. It also eliminates some negative feelings associated with the word addict. We use the word recovery instead of rehabilitation. That's because recovery is a long-term thing that you work towards all the time. Rehabilitation is time limited. You go to rehab, you're fixed, you're out. That's not what this is about. So that's why we use the term recovery. So we say people are in long-term recovery instead of being a recovering addict. Again, that word addict has a very negative connotation to it. And this also represents long-term health and wellness, not ongoing state of illness. And then recovery capital. So this is going to be a really important term. These are the resources that someone has to make them successful in recovery. So you have to think about if someone doesn't have a house and they don't have a job and they don't have enough food, that's adding all kinds of stress to their life. So where do they find the energy to work towards trying to do the hard work of recovering from a substance use disorder? So recovery capitals were developed by White and Cloud in 2008. William White is a leader in recovery concepts, and he's an advocate. So we have 4 categories: personal, cultural, family, social, and community. Personal are those things I talked about, like job, your house, having food, having clothing. It also includes things like hope, purpose, self-esteem. Those are things that are hard to give someone, but there are ways to help them develop those things. Cultural capacity is a form of community capital. Cultural capital, and it's locally based. So if you think about your town has a culture that's different from the next town over. And many people don't think of it that way. Working in rural areas, I don't think of all of rural Indiana is the same. Each county, each community has its own culture and flavor. So it's important to acknowledge those and to be aware of those as you're working and not just lumping everyone together. Family and social capital, those are the people around you. If you come out of treatment and you've started your path to recovery and you go back to live with people who are still using, that makes it really challenging. Things like, this is also where religion comes in. Many people find strength and support through religion and through churches. And so that's part of that family social capital. And then lastly, community capital. So we'll talk about these a little more, so I won't go into details. However, this is where law enforcement and the justice system can fall in, because that's how a whole community is approaching people with substance use. So I'm going to hand it over to Michael now. He's going to talk a little bit about how recovery capitals and that section on community capital crosswalk over to community capitals in the sense of community development.
Thank you so much, Nicole. This is an experiment. I figured when I started, everyone would drop off the call, but everyone's staying on, so that's good. As community development extension professionals, a lot of what we've covered so far was quite honestly news to me. As an economist, as a community development extension professional, I work in a lot of realms, but substance use disorder was not a realm that I had spent a lot of time working in. And so it's been an absolute pleasure and very, very interesting learning from Nicole and working with her as we apply these concepts in a variety of places. And later on in the presentation, we're going to get some tools that we use, and we've got some exciting news about a grant and some opportunities for you all to potentially participate in this work. But connecting it to community development, comes down to the community capitals, if you will. And when Nicole and I first started discussing this work, and this was back in the spring of 2019, as we were writing a different grant, she was talking about recovery capitals and I was talking about community capitals. And as we were talking to one another, we realized that we weren't necessarily talking about the same thing, but we were talking about something that was very, very much related, if you will. And so starting all the way from the left, we have our community capitals, the 7 community capitals that many of us base our work on, you know, financial, political, social, human, cultural, natural, and built. And in some of the other work that I've done, we've taken human capital and split it apart. So we've got skills and education on one side and we have health on the other side. And so I felt like, oh, we were taking care of this whole issue by splitting those two apart, and now we're focused on the health aspect of it. But in working with Nicole, she helped me realize that we need to be able to crosswalk the community capitals with recovery capital. And so in Turtle Mountain, working with Aaron and Wiley and Jill, we did our typical asset map that all of us do, you know, seemingly on a daily basis, the sticky wall, the Post-it notes, and had people really brainstorm about the different assets that were there in the community. After we did that, we then looked at it through the lens of recovery capital. And not all of the assets that were brought up necessarily fit into the recovery capital model. So as we were reorganizing things, some things stayed and some things were kind of put in the parking lot, if you will. So we went from the 7 community capitals to the 4 recovery capitals. And it was understanding those assets that helped us, helped inform the work that we're going to talk about as we move forward. As we operationalize this, I wanted to point out that we have this a model, the policy systems and environment model, that we use a lot in FCS and HHS, health and human sciences or family consumer sciences, where we're looking at the individual, we're looking at social, economic, and environmental factors, we're looking at physical factors, and we're looking at policy factors. And so how this work is evolving is starting with the community capitals, moving to a recovery capital model, then begin moving into a PSE model. And it's very small, and I apologize for that. This is just a seed of some of the work that we're going to talk about in a little bit, is how do you crosswalk the 7 community capitals or the 4 recovery capitals with the PSE model, the policy systems and environment model. And this is an example of some of the work that Nicole and I are engaged in now. So when we go through the community development planning process with communities to try to develop a recovery-oriented system of care, we have an arsenal, if you will, of strategies that are evidence-based, that work along the continuum of policy systems and environment, informed by the 4 recovery capitals or the 7 community capitals, that we can help engage communities and help them understand what strategies exist and what strategies might be culturally appropriate or locally appropriate for them to use to try to either begin creating a coalition, which we'll talk about in a bit, creating, scaling up to a recovery-oriented system of care, and generating action plans for these different organizations that are involved in this work to help address the substance use disorder situation. So this is really part of where the rubber hits the road, and where we as community development extension professionals can really contribute to this work alongside our health professionals, like our colleagues in nursing, for instance, or in health and human sciences or family consumer sciences. I'll hand it back off to you, Nicole.
Okay, so with all of that foundational thing, the other thing to keep in mind is there's multiple pathways that people go into substance use and multiple pathways into recovery. So as we put together all these recovery capitals and all these community capitals, there is no one size fits all. So multiple pathways into use. Some of this may be redundant, you may already know this, but you know, prescription drugs, someone having their own prescription and they can't stop, they go back for refills. Some can stop, some cannot. Again, those risk factors play a role. someone else's prescription, so taking something that belongs to a family or a friend, either given to you or stolen. And then I want to just highlight a little bit of misquoted research because it's so often misquoted. So in 2014, there was a paper published in which they found that 75% of heroin users began with a prescription opioid. That is not the same thing as 75% of heroin users began with a prescription from their doctor. So again, they began with a prescription opioid, but that was not necessarily theirs. It could have come from what is known as a farm party, where people gather socially and bring drugs to share. It may have been stolen from someone or given to them by someone. So it's just really important that when you hear these they're often very accusatory statements towards physicians that they caused the heroin problem by giving out prescriptions because 75% of people who use heroin started with that prescription. That's not an accurate representation of what the research says. Okay, I just have to get that out there. And then recreational use. So friends providing access or transitioning from other drugs. Often people who go down the path of opioids say, well, I was already a heavy drinker to begin with, or I was already smoking a lot of marijuana, and this was the next evolution of my drug use. So as there are multiple pathways in, multiple pathways out. So William White, who is one of the developers of the Recovery Capital, says there are many pathways and styles of long-term recovery. So and working in this space, it's important to acknowledge that everyone has their own path and all paths are valid. One size does not fit all, and you're required to have a menu of treatment options for people so that they can choose what works for them. People also have varying levels of recovery capital. So what they're going to be able to participate in and what's going to be appealing to them is going to be impacted by that as well. And we must be open to all the pathways. So next poll. Again, if you have you need to text to 37607 to get in. But A or B, A is yes, B is no. If someone struggling with substance use asked you for help, would you know where to go to find help or how to help them? Okay, so a little more than half of our group would know how to help someone, but we still have a lot of people who don't know where those resources and assets are. And this is something I found in my research and in the communities I've worked in. Often there are resources, there are treatment options, but no one knows how to access them, and they're not easy to access or they're not connected. So we're now going to do a breakout session because this is not just a lecture, this is a workshop. So what we're going to do is I'm going to randomly assign everyone into groups, into small groups. You may want to turn on your cameras and unmute yourselves so you can talk to each other. And what you're going to do in these self-facilitated groups, so we will not be in those groups. We may pop in to check on how things are going. But in your group, talk about what you know of task forces, coalitions, or other community groups addressing substance use in your own communities. And since people come from all over, this should be pretty interesting to see what is going, how different communities vary. Keep these ideas in mind then as we move through the next concepts and compare what you heard and what you have in your community to what we're talking about here in the next few. So we are going to do our breakout rooms here. All right, so you'll just need to accept going into the room.
Hey Nicole.
Hi.
I tried it. It said that I accepted the breakout session, but then it kicked. I'm using my tablet, so I'm using the app. It kicked me out of the app when I
Oh,
accepted
no.
it.
Hang on. Let me assign you to a group.
Okay, thank you.
All right, try again.
Nicole, I was partnered up with Cheyenne and Jill, so it was like old home week in our breakout session, which was nice.
Yeah, I didn't, for some reason, I don't know if I clicked make you host, if that gives it away from me or if that just adds you as a co-host. So I wasn't sure, so I didn't.
Oh, so did you attend any?
I popped in on one room and they were having a good discussion. So.
Oh, cool. Yeah, we had a good discussion as well. It was good to hear Cheyenne and Jill's perspectives on it.
Okay, so everyone should be back in 3, 2, 1. There we go. Everyone's back. All right. So let's keep going here. So keep thinking of those thoughts of what you've heard about and what you have in your own community as we continue to move forward here. So the next thing we're going to talk about is the recovery-oriented system of care. So this was this is the statement published by SAMHSA in 2010 describing what a ROSC is. And they said, I'm just going to read this, a coordinated network of community-based services and supports that is person-centered and built on the strengths and resiliency of individuals, families, and communities to achieve absolute and improved health, wellness, and quality of life for those with or at risk of drug problems. So what's interesting here is that it's person-centered, so we want to keep the person and their needs at the center of things, and they about things we talked about. Community, strength,
people, if you can mute Ken.
Okay, sorry about that. All right, so most groups think of a ROSC as used by healthcare organizations or a treatment provider to create a network for their patients. So you want to have that kind of network, community network, who's in the community that I can connect my patient to. But we apply the idea of the ROSC to the whole community. So what if everybody is a component of this recovery-oriented system of care, and we borrow entrepreneurship model and say there's no wrong door. So no matter who you contact in the community, you can get into the right path for you. So it's when we apply the community capitals, there are many important components to recovery, not just treatment and healthcare. So in kind of staying true to that community recovery capital spirit, we think, how do we incorporate everyone? So why are we so focused on community? Well, community responses are very powerful. First of all, federal and state responses are slow. They can take years to pass legislation and then even years longer to implement it. Blanket policies ignore cultural nuances. So what works in New York may not work in Montana, and what works in Florida may not work in California. So it's really important for communities to develop their own, that maintains their own cultural spirit and values. Stigma is very, very powerful. And the best way to combat stigma is through knowledge. So building knowledge from the grassroots level helps communities change their perceptions and how they approach things. Meeting with other people in your community expands your knowledge. And when you know someone, it can change hearts and minds. So again, I use this technique of having people think of who they know that has either struggled or has a family member who struggles with substance use, because then it kind of opens your thoughts a little bit and it's not those people anymore, it's your friend. And the community, using the community collaborations and coalitions, it helps people see a bigger picture. It helps organizations and individuals see that they're not alone and there's people next to them, right there, close to them, not in some far off federal government land, that are there to help and support each other. So there's a couple different community frameworks, community system frameworks. We apply systems thinking in our approach at the community level. So systems thinking at the community level, you think of organizations and agencies as components of the system.
Nicole, let's pause for a moment and make sure that everyone's on mute. I think you're good.
Okay, so each component has its own feedback loops, inputs, and outputs. What does that mean? That means each agency and organization has its own agendas, its own sources of income, its own expenditures, and its own purpose. But those outputs and inputs can move between components and influence their performances. So if we look at the law enforcement and justice system, those have each their own agendas, inputs, and outputs, but they definitely are tied together, because the people that law enforcement arrests and flow into the justice system. So they do influence each other. And then when we look at the system at whole, we include all government agencies, elected officials, community members, businesses, and other community organizations. Sorry, mouse problems here. Okay. So different models. The first model we'll talk about is the hub and spoke model. So you have a center hub organization that connects to spokes like a wheel and provide comprehensive services to an individual. So Vermont and Washington State have led in the development of state-sponsored hub and spoke substance use treatment models. Both of those states use Medicaid funds to support their hub and spoke models. And for instance, model, they have a federally licensed opioid treatment program, which is a methadone clinic at the center, that's the hub, and they connect to other services and other components. For law enforcement can make referrals there. They also want to hand off their patients eventually to primary care, and they pass them back and forth. Child protective services can be involved, social services are involved. However, with this model, you see none of the spoke components are connected to each other. So you don't necessarily have a connection between law enforcement and social services or primary care. They all feed through this hub. In Vermont, they still have some significant gaps in services where they haven't been able to establish a hub, or they haven't been able to establish connections between hubs and spokes, because it requires that providers want to participate. So if a primary care provider says, I don't want to participate in this model, and they're the only one in an area, you have no model. So this is not my favorite. Another example of a model is a complex adaptive system model. So in this, you look some characteristics of the complex adaptive system model that make it well suited to community work is that it's nonlinear. So communities are nonlinear. The connections are unequal, they're all over the place. That kind of reflects a complex adaptive system. You have heterogeneous timing of change. So what does that mean? That means that you could have an election that replaces one elected official but not another. You could have changes within one organization but not within another. And so the timing of these changes are not at the same time. And so the complex adaptive system model is adaptive to be able to absorb those changes and incorporate them into the model without it completely defuncting the model. You have constant feedback loops, you have rapid evolution and change, and optimally in a complex adaptive system model, there is no central control. So everybody's driven by a shared goal, but none of the components, none of the stakeholders are leading the charge or in control of the model. And this is really important to think about. Also, this still works if some people don't want to participate. So if you, for example, have a hospital in your community and they say, we want nothing to do with this, you can still pull together other resources and create change to help people in your community without the participation of that hospital. Whereas with the hub and spoke, if the hospital says, we're not in, you don't have a model. So let's talk a little bit. I know most people here are very familiar with community coalitions, do a lot of work with community coalitions, and they already exist in many forms in most communities. They could be called coalitions, collaborations, task forces, and we're not advocating to replace existing coalitions by any means. They've done strong work, but they could incorporate, by incorporating systems thinking and striving towards becoming a ROSC, a substance use coalition can really kind of redefine and produce rapid changes in their community. So stakeholders, as we know, are all of those different model components. It's people who are invested in some way in the topic that's being discussed. So when we talk about substance use, definitely law enforcement, justice system, usually elected officials, prosecutor's office, sheriff, the mayor is often very concerned about this, but you also have treatment providers, you have recovery residences, you have religious organizations, you have community members, you have people who are struggling with substance use or in recovery. They're definitely stakeholders in this because they have something to contribute and it affects them. But what happens when a stakeholder is a leader? What happens when that coalition is led by the sheriff? Well, changes in his department are going to be reflected in the entire community coalition by his agenda and his department needs, which is why we've kind of moved to this model and advocating for a non-stakeholder leader. So in our community here in Tippecanoe County in Indiana, the United Way leads our opioid task force, which is now the Recovery and Resilience Network. And what this does is it allows everyone to sit at the table as equal partners and not question that the leadership has their own agenda and their own motive. And it's really made people far more open in sharing and being willing to work with each other when they're not questioning a motive or an agenda. So now we're going to do our second breakout, and I think I can put everybody back into the same rooms, but if not, you'll get to meet some new people. And what you would want, what I want you to do, and I'm only going to give you about 10 minutes for this, is to work in your small group to create a list of stakeholders you would include in a coalition and a community map. Actually, I'm going to give you just 5 minutes. So just think of the list of who you would include in your coalition for a community. Okay, let's see if this will work to put everybody back in the same. All right, so go ahead and join those rooms.
Just to remind everyone to mute.
Okay, so as we move forward, think about that list, because the next question is, were you missing any key components or stakeholders? So again, going back to key assets for recovery, healthcare, social services, law enforcement, first responders. These are all key components in that recovery model, because it's either where people enter the system or where they have support for those recovery capitals and they can get help for early and long-term recovery. So if you notice, this is our recommendation wheel. So look, think about the lists you made in your groups. Are you missing any of these components? This is who we recommend to be on a coalition, and I'll read them. So community members, business leaders, community leaders, elected and non-elected, law enforcement, justice system, healthcare providers and leaders, religious leaders, elected officials, substance use treatment providers and leaders, people in recovery, and social service providers. So again, this is King Arthur's roundtable. No one is the leader. These are all people sitting together, being able to share and contribute and work towards a common goal. So what we do next is we create a map of our community to show how it looks as a recovery-oriented system of care. The map can take a variety of formats, which you'll see, and the coalition should have representation from most of those components. We use the complex adaptive system model, and we focus on the individual. So you'll see they're the ones moving through the system. We use a mixed methods approach, collecting interview qualitative data as well as numbers or quantitative data of community metrics. So we also, you want to focus on crisis moments. This is where people are likely to seek treatment because they've had one of these crisis moments inspire them. So an ER visit for an overdose, Child Protective Services taking children is a huge motivating factor for women. Loss of relationships, divorce, or your spouse or boyfriend, girlfriend leaving, or an arrest, an incarceration. That's another huge motivating factor. So we also want to include measures of substance use. So overdose mortality is not a really great proxy measure, but it's one of the few we have that's more consistent. It is delayed. For example, Indiana, the 2018 data was only available, finalized in January of this year. And it can be affected by policy change. So in Indiana in 2018, they began requiring coroners to do toxicology on all deaths. So 2018, the numbers changed a little bit. Overdose visits and 911 calls, again, not in real time. Not all users overdose, so it's not really a good measure of how many people are necessarily using. It's only available really as aggregated numbers because of privacy and again, policy. And again, it's a proxy measure. The SAMHSA National Survey on Drug Use and Health, we use this one a lot. Again, not real time, couple years delayed. It is a sample survey, but they do use robust methodology. So we like using these numbers to estimate how many people have substance use issues. And then CDC opioid prescribing rates are fairly easily available, but just keep in mind those are based on a pharmacy sample survey, so they're not actual counts. In some states, you may be able to access the prescription drug monitoring data. Indiana just made some available last year, so we can get about 2 years worth of actual number of prescriptions that went out. So let's look at a map. What does a map look like? This is a map we put together last fall at Turtle Mountain in about 4 hours. And it's just a starting point. And so you can see there's big components on here. We have risk factors. We have the hospital, justice system, treatment, recovery supports, recovery capitals, additional supports. But we also have a lot of flags of we need more assessment of local recovery resources. We need to estimate demand. We need more assessment of recovery capital. Now, since we created this map, we have done the estimate of demand. And we're putting in lots of work to try and put in some of these connectors and add some of these missing pieces. This map also reflects the culture of Turtle Mountain because you have this at the bottom, their heritage and history. Nature is very important to them. That's one of their assets. The traditional arts, another asset, ceremonies and faith. Those are things that provide strength and resilience. And a few may already take that path to avoid substance use and end up straight at wellness and skip this whole part at the top. So that's kind of an interesting cultural component that is really specific to Turtle Mountain. So the next two maps I'm going to show you are the ones we did in Tippecanoe County. These both took about 2 months each to create. So you'll see they're very, very complex, and they're going to be hard to see small, and I don't intend everyone to see every component, but just get a feeling of how complex these maps are. These are printed on 4x8 vinyl posters so that they can go up and down and not tear, and they're taken all over and presented at meetings and used to guide the work and guide decision making by the components and the community agencies and organizations. What's really interesting to note is from 2018 to 2019, how many of the red dots or the gaps and barriers have disappeared in just 1 year. So this was 2018. And what's important to note is on the very left, the community member. This is their pathway as they go through, how they become involved in substance use and how they come out of it. This map is also very heavily focused on opioids because this was an opioid task force at the time. And so that's the direction that we went. The blue flags are our quantitative data, our estimates for demand and overdose visits, 911 calls, arrests, things like that. What's also really interesting is when we put up this map, our law enforcement and justice system were working independently of everybody else. They kind of believed that they were all on their own and they were going to deal with drug use and with the opioid crisis. And when this map went up and they saw where they fit in with others, it changed their entire trajectory and their entire direction that they wanted to work. And they started reaching out and working with other components far more because everybody was at the same table now. So look at how many fewer red dots there are. We still have some, but a lot of them disappeared. Again, very complex. I don't expect anyone to read through each one. This map, we did add substance use in general and mental health as well. So it's not an opioid map anymore. But we still have some gaps. You can see these ones, that red dots that are shaded, kind of red to white. Those are projects in progress last year. And I can honestly say that some of these have disappeared for this year. I usually do these map updates in the summer. So I'll have another updated map in August to reflect another year's worth of change. And I know that some of these more of these red dots are going to disappear. The blue flags that are shaded down means that those numbers improved over 1 year. So we had a 20% reduction in arrests for substance use in 1 year in our county of 185,000 people. So I think we're having an impact. So what are our next steps? And I'm going to hand this back over to Michael, if he doesn't mind, to kind of talk about where we're going next.
Sure. Thank you so much, Nicole. I hope all of you, like me, find this stuff fascinating. Some of it is community development extension professionals is a little mind-blowing. I was meeting with Cheyenne and Jill in our breakout, and it's probably counterintuitive to some of us to think that this should not be led by one of the stakeholders. So often when we do our work, we say, oh, well, if this entity is not interested, then forget it, it's not going to work. And really the approach that's being taken here leaves the door open for everyone, and they're always welcome to come, but this ROSC is going to work in spite of the fact that they're not there. And once the ROI associated with being there unveils itself, people begin to come to the table, and it's a game changer. And quite frankly, in Turtle Mountain, we've talked a lot about whether extension might be that, you know, honest broker, if you will, that can bring together the ROSC. It's good to have linchpin institutions and linchpin people there at the table. But if we can have extension there at the table, making this happen or catalyzing these things, what we're seeing is that it's going to lend itself to more sustainability as far as the system is concerned, this adaptive system that we're trying to build. So many of us as community development extension professionals, we need to have the 3-ring binder that we can take off the shelf that helps us understand how to do this. And there is no such 3-ring binder right now, but we are excited to announce that we were awarded a grant through the North Central Cooperative Extension Association. This is the extension directors across the entire North Central region. They awarded us a $100,000 grant to work with Illinois and Ohio State Extension to create the 3-ring binder, if you will, to help, so we can help extension professionals like ourselves across all program areas help develop these ROSCs using this complex adaptive system. And so we're going to be working on that between 2020 and 2023. We have a meeting next week to kick things off and get started. The extension directors are investing in us and essentially requiring us to get this work out as quickly as we possibly can to the North Central region. And so we're going to be piloting this in Indiana and in Illinois and in Ohio. And their expectation is that we then pilot it in other states across the North Central region as this curriculum is developed and as we continue to not only get the materials and the process in place, but get a group of individuals across the North Central region and beyond working on this particular topic in some sort of working group. So this is sort of like seed funding to get that extension working group going across program areas. So we're excited about that. If you're just as excited as we are, please, send us an email. We're going to have our contact information here at the end, but we are seeking people to partner with and to learn from and so on. So we're really excited about that. We're going to continue working with Turtle Mountain, our friends Aaron and Wiley and Jill, all of whom are on the call. This work started through the READY initiative, which you may have heard of. Purdue and University of Kentucky have been working together with our sister land grants across the United States in 9 different regions, including U.S. Virgin Islands, Turtle Mountain, Ohio, Florida, Kentucky, Indiana, Illinois, Wisconsin, working on rural economic development innovations. And Turtle Mountain was interested in this because this is an opportunity to help the workforce. It's an opportunity to help with economic development. And the recovery campus that's being developed there right now is just an amazing idea, a local idea infused with culture, trauma informed. It's just, it could be a presentation on its own, and very likely when we're in Idaho next year, we'll be presenting on how this all occurred, and hopefully we'll have really good news coming out of Turtle Mountain with that. So we'll continue to work with them through 2021 with Turtle Mountain Community College and all the partners. And the outcome of READY is to have the action plan in place to create the ROSC, and then further funding that we hope will come. We already know that there's some coming. Hopefully there'll be more, so we can actually implement the action plan. Nicole has worked with a group of individuals to create the clinical plan associated with the center, the business plan associated with the center, and now we're action planning as far as the ROSC is concerned, and really trying to build out and develop the vision for the entire campus that will not only include the recovery center, but include recovery residences, include a confidence course, include an equine center, include trails, include a sweat lodge, a lot of amenities that are not only going to be used for the center, but it be used by the entire community. We've been speaking of a community building since the project started, and we have just learned a lot from Aaron and Wiley and Jill through the process, and excited to continue to work with them. And then Nicole continues to research the role of complex adaptive systems in successful ROSC development. This is important work. We can't do our extension work without the requisite applied research. And from a community development standpoint, Nicole, I think, learned early that community development stands between doing this successfully and not doing this successfully. And so I'm hopeful that she and I will continue to collaborate in this, and that we'll be able to work with folks like you that are interested in addressing substance use disorder issues, looking at how we can use complex adaptive systems, how we can use the concept of the ROSC, the decentralized ROSC, how we can leverage the health coalitions that we're already working with as community development extension professionals, and really up their game as far as addressing substance use disorder. With that, Nicole, I'll hand it back to you. We have about 15 minutes left, I think, so we'll be able to answer questions as well.
So we need to thank our sponsors for helping make this whole conference happen remotely. And then this is our contact information. So our emails are there if you'd like to reach out to us. But let's go ahead and open it up for 15 minutes of questions.
And you can take yourselves off of mute. We've held you hostage for a while. Kristen, you want to start us off?
Yeah, so I'm very interested in the idea that you mentioned of the decentralized portion of the stakeholder not being the leader.
Mm-hmm.
How do you, so I think when you mentioned United Way was, so are they just providing staff to facilitate, or are they like, what's their skin in the game to keep them involved long term?
So the United Way sees their work on this as their only goal is to see the community succeed. And to them, community success is moving those metrics that show that substance use is going down, helping, our businesses. This is a very manufacturing heavy county, and our manufacturers are saying they can't find employees, and they're struggling with keeping employees because of substance use, and they're struggling with being able to hire people because of substance use. And so by helping decrease the number of people with substance use issues in our community, it helps those businesses. It helps our law enforcement. It decreases our crime rate. These are all community metrics of a healthy, well community that United Way is dedicated towards helping provide. So yes, they provide staff. The coalition, the Tippecanoe Recovery and Resilience Network is what it's been renamed, has 300 people that participate on and off. There's about 80 that consistently participate. We meet not quarterly, but as needed, which turns out to be about quarterly, and we meet in the public library. So it's a safe, like non-affiliated space. And that's their skin in the game, is they want to see the community succeed, so they see this as worth their time. The county over has an AmeriCorps volunteer that has a year of funding to do the same thing through United, and is working under United Way. And so they're doing the same thing, and they're seeing really good outcomes there too. I have a grant, actually Hair on Fire grant, going in to do some more work with that county to evaluate how their system is working as well. But this concept of the non-stakeholder leader, it's similar to a, I forget the name of it now. Hang on a second. It's similar to a collective impact backbone organization, except that in collective impact, usually the backbone organizations are also stakeholders. So different from that. But it's a model that really, in 1 year's time, we had a meeting and we had all our treatment providers in one room. And one of them said, a year ago, we wouldn't have talked to each other like this.
Yeah, no, that's great, because in Arkansas, we're being pulled into facilitating a lot of these types of conversations from the county jail perspective. The counties and the jail administrators are realizing they need programming in their jails. They need discussions about how to support people. And they're like, but we can't lead that because we want to participate. So interesting stuff. Thank you.
Hi. So my name is Nicole Brazil, and I am brand new to Cooperative Extension at the University of Kentucky in the Department of Community Leadership Development. But I was formerly a sociology professor at Western Kentucky University, and I was working in the satellite campus in Barron County, which is just a small rural farming and manufacturing county in Kentucky. And I'm particularly interested in the role of stigma and fostering how we break through that stigma to foster some of these community conversations. One of my areas of interest are in how we use storytelling to foster community transformation. And I had my students doing, using a model of Marshall Gantz's work around, you could either call it leadership storytelling or public storytelling in Barron County, to start to talk about some of the rental problems there. So even people who are directly affected by the problems of substance abuse or unfair eviction or food insecurity don't want to talk about them, right? And their leaders talk about them, but in very general, abstract ways. They know people are affected, but they don't really get into the details of why this has happened, what it means, what people's lived realities are, how you move forward through those process. In other words, it's not personalized. And we have a new extension specialist at the University of Kentucky who's fantastic, who works in this area, specifically in this area, Alice Ellswick. And we were talking about him a little in our small group. And one of the things that he does so beautifully is a version of leadership storytelling where he incorporates his own story with the science of how addiction happens and who is more vulnerable, along with what the reality of recovery really means, and thinking about what broader supports can and should look like. So marrying the science, right, with a community perspective with one's own personal narrative. And I'm really interested in that question about, especially in Kentucky, how we develop leadership storytelling at the local level, right, which is risky, but how we develop it in ways to break through the stigma so we can talk about this in deeper level ways, instead of little pieces and parts of the story. And what kind of advice or suggestions you have about how we might be able to contribute as community developers to this.
So one of the things that really, just when you were talking, one of the things that really struck me was the concept of peers. So somebody who has lived experience and shares their story, it's been really powerful here. So when we talk about our maps and the changes between 2018 and 2019, one of the key things that happened was they actually used the map from 2018 in their grant application to get state funds to start a quick response team. And the quick response team sends peers out to people who've just overdosed. And they get their information from the police because the hospital won't share. And so they go out and they meet with people in that first 72 hours post-overdose. And I know this is a model that's all over Ohio, it's in Kentucky, it's all over the country. But they didn't have that many people that they were getting referred. So they really partnered with law enforcement, and now they go to the jail and they go to corrections and they meet with people there. But having those peers in our community collaborative meetings, having them talk about their experiences has really helped change that stigma. The way our law enforcement looks at things today is 180 degrees from a year ago. And so anytime you can have if you can foster a group to be willing to share their stories, I think that's where you start. But you have them come to those coalitions and share their personal, this is what happened to me, this is how it happened, and this is how I got out of it, and this is what it takes for me to stay here.
Nicole, may I jump in just real quick?
Please.
Nicole, did you take over for Lori Garkovich?
I did, but I cannot possibly be the new Lori. No. I can never fill those shoes.
No, well, welcome. It's very nice to meet you. I'm adjunct at the University of Kentucky. I work a lot with Allison Davis and SEDIC.
Oh.
And so you and I will need to connect. This is how NACDEP works, right?
I can't believe we haven't met already. That's embarrassing.
I know.
Well, so, COVID didn't help.
Yeah. I just wanted to throw this out, and I'm so glad that we have Aaron and Wiley with us. When we were in Turtle Mountain, Nicole and I flew up there as part of the READY program last November. And we were there, we were gonna give this presentation that we had given the 8 other regions across the United States, and talking about rural economic development and so on and so forth, and trying to build some capacity to move forward as far as planning is concerned. And at the last second, Nicole and I decided to throw that out the window. And we decided to do something completely different. I think one of the key things that we did is we listened, and we really wanted to ensure that we had a safe space for everyone that was involved to kind of tell their story and talk about how they fit into the system of recovery that was currently there in Turtle Mountain. And Erin did something very, very brave. Well, actually, she did something very smart, and then 60 people did something very brave. She said, Nicole brought up the idea of a recovery rally, something that had never been tried before, I don't think, on the reservation. And so Erin, because she's crazy and wonderful, she decided to put out a Facebook post and just out to everybody that, because Facebook is a real means of communication up there. We're going to have a recovery rally tomorrow at 1 o'clock. Come to the casino if you want to tell your story or whatever, or if you have someone that's in recovery or have lost someone. And just opening up that venue, we weren't sure if one person was going to show up, 5 people, 10 people, whatever, because of the stigma around recovery. And we wound up having 60 people show up. And we didn't say it's going to be from 1 to 3 and blah, blah, blah. It starts at 1. And we wound up, Erin, correct me if I'm wrong, I think we were there till 5 or 5:30. We had over 60 people show up, and nonstop people were telling their story, and we were there for that many hours until after 5 o'clock in the afternoon. And if I remember correctly, only 7 people spoke. And it took that long, and we provided that much space and opportunity for those 7 people to share their stories, and then allow the community that assembled to embrace them. And we wound up having, there's a small recovery center that's there on the reservation, and all the people that were currently in recovery at the center came to another meeting that we held, and we had the opportunity to hug each and every one of them. And so I was so impressed with the way the stigma just kind of evaporated, and the community gathered around and said, this is so, I'm sorry, effing important, that we can't not do this, that we have to come and we have to afford people the opportunities to tell their stories. But I appreciate what's going on at the University of Kentucky, and I had heard through Allison and others that really cool things were going on. And I know North Carolina State has a cool program on storytelling. I think that's a way that community development extension professionals can contribute to this, is providing those forums, be they facilitated or not facilitated, but provide the capacity for people to be able to tell their stories and be embraced and erase that stigma. Erin, I don't know if you want to add anything to that from the perspective of what went on at Turtle Mountain and what continues to go on in Turtle Mountain as far as people telling their story and the importance of storytelling. And I know our time is nearly up, but Erin, do you want to add anything?
It was a great day. I do think that it went on longer than 5. I want to say like 7:30. I ended up leaving to go home. I was able to also share, you know, when you get everyone there to open, it's very heartwarming. And I was able to share that I myself am 3.5 years into recovery, and it was great to share with that group of people in the room. And you just our actually governor's wife here in North Dakota is huge into making sure that the stigma is gone, and she goes around and she tells her story, and she has a program here called Recovery Reinvented that we're trying to get involved on our reservation. It's been great working with Nicole and Michael, and I can't say enough good things about them. I'm glad we get you for another year. We're excited. Wiley, do you want to add anything?
Only that it was a great experience to see everybody going up there and telling their stories. And some of them were just like heartbreaking, and they didn't leave out any details, and it just gives you some insight into what people go through and what kind of fueled them going into recovery or even becoming an addict themselves.
Yeah. There's one mother we had told her story and how she lost her son, and she's still going around. She took the peer support training, and she's heavily involved in the recovery on the reservation. She's just amazing, and it's been quite the year.
I'm really impressed.
Well, Nicole, let's definitely link up after this. I appreciate that, and welcome to trying to fill Lori's shoes. Good luck with that.
Not fair.
do we have time for, it's noon, so I guess we don't have time for any more questions. We can stay on as long as we want. The joy of there being a virtual thing, and new member orientation I see starts at 1 o'clock. So if any of you are new members, please, as a former president of NACDEP, I implore you to join the new member orientation. It's usually a lot of fun. And there's a 1994 meeting. Actually, Aaron and Wiley at 1:30. The 1994 is the Native American land grants are actually meeting at 1:30. If you want to join that, that might be interesting to find out what they're doing. 1890s are meeting at 1:30 as well. So do check your conference schedule and continue to participate in this very strange adventure that we're doing. Those of us that have been with NACDEP long enough, this is our favorite time of year. And to do it this way is a little heartbreaking, but also heartwarming. So this will be recorded, and someone did ask if we'll share the slides, and Nicole, I think we have every intention to share the slides. If you want them sooner rather than later, please shoot us an email at one of our emails listed there. So I guess with that, I'm happy to stay on, but by no means does everyone need to stay on. If there's another question or two, Nicole, if you're available, we'd be more than happy to field them.
I have another question if nobody else does.
Sure.
Opening it up to everyone else. I'm interested in, you know, as far as for the people who participated in this organization, if they had any type of measurements that they were using to gauge success other than like from the jail perspective of being rearrested, or you know, maybe, you know, other than being rearrested or relapsing, like were there any other type of measurements that they used?
So so this is something that I'm really passionate about, is that in a community, that coalition needs to create their own metrics for what's valuable to them and what's important to them. And this is again going back to my feelings about how communities have individual cultures. And so I hate to imprint that these are the metrics you should use. I like to say these are suggested metrics that we've used in other communities, but you'll have to come up with your own. So, and just an example, in Belcourt with Turtle Mountain, we don't use the SAMHSA survey data because it's reflective of a much larger area, and it does not reflect necessarily the culture and the circumstances on the reservation. So we had to pull data from other sources because I did not feel that that was a reliable measure for the reservation. And again, that goes back to their reservation has their own culture. It's not necessarily the same culture as the rest of the county or even the rest of the state. So I want to be respectful of that, and so that's why we go about it that way. But each community has to decide on their own metrics. In our community here in Tippecanoe County, things that are important, again, the response from businesses, the response from employers, from the Chamber of Commerce, that's a metric that's important to our community here. And so they kind of try to incorporate some of those measures, unemployment rates, turnover rates, things like that. Maybe those are things that we would want to include here. Primarily, we've looked at arrests and ODs, overdoses that go to the ER. That's an important metric. Our community is concerned about how many people have to go to the ER for an overdose. So that's a metric that we use. We also have a syringe exchange program in our county. So that's another metric that's important for us to report on, is how many people are using the syringe exchange, how many syringes are exchanged, but more importantly, how many people that use this syringe exchange are referred to treatment. And that's huge. That to me is validation of the program, because as people go there, there's a peer recovery coach there who talks to them about what recovery could look like. And after a couple of visits, after meeting with her every week, you know, for a couple of visits, they say, well, maybe I want to start some treatment. Where would I go? And they get referred into treatment. And there's good, solid research that shows that people who use syringe exchanges are more likely to enter treatment than people who don't.
So Nicole, if I may, Kristen, I'm going to kind of turn this on its head and show my true colors as an extension administrator. When we talk about metrics, we also need to be thinking about our impact measures and so on that we have to report on as far as being extension professionals. And we have less leeway than I guess Nicole does, where, you know, you can sort of make them up based on the local, you know, we have 15 that we report on in the North Central region. The South has its own sort of list of community development metrics that we report on. And some of them I think are quite relevant to the work that we've discussed today. Some of them are perhaps less relevant. You know, in the North Central region, we actually measure the number of jobs created. And as Aaron and Wiley can tell you, we're in the process of trying to put together a workforce development plan with the community college there to make sure that people are prepared to take the jobs that are going to be created through the center and the recovery residences and the other amenities that are going to be on that recovery campus. And so indeed, we'll be able to say that jobs were created based on the work that we did. But there's other measures perhaps that are less relevant to what we're doing. I think the biggest challenge, and having done this with another program, our Creating Healthy Communities program, our biggest challenge is that while community development is going to be front and center in this work, we can't forget how critical FCS is going to be, how critical 4-H is going to be, and how critical even ag and natural resources could potentially be as well. In fact, we have a landscape architecture professor that's working with Aaron and Wiley on the Turtle Mountain project to frame what the campus could, should, would look like. And he's going to be doing a charrette with them to get public input, community input on what the campus should look like. The 100 acres has already been purchased. We've already sketched out from a 30,000 foot level what things are going to look like, but now get down to the nitty gritty and think about, okay, land use and so on. And is there tourism potential, economic development potential, youth development potential? And so when you start crossing program areas and trying to account for impact, that becomes the difficult discussion of how do you crosswalk common measures from 4-H? How do you crosswalk FCS impact measures, CD impact measures, and A&R impact measures when we're all measuring different things?
Right.
It's doable, but it requires a very intentional discussion and sitting down with your fellow extension professionals trying to figure that out. And that'll be one of the challenges that Nicole and myself and the others from Illinois and Ohio are going to face as we put together this curriculum. How do we crosswalk all the different things that are going on in the different program areas to ensure relevancy, right? So it might be relevant on the ground, but it becomes irrelevant to an administrator if you can't report on anything, right? Then you're all of a sudden doing something superfluous. And so we want to make sure that we bake into what it is that we're creating all of those important indicators that we use in extension to talk about the impacts that we're having, but also note that the local groups that we're working with, they're going to have their own notion of impact. And I'll end my diatribe with this. Nicole really impressed upon law enforcement in Turtle Mountain that you can't arrest your way out of the problem. And so the single metric that they were using was number of arrests, okay? And our goal should be to diminish the number of arrests because we are dealing with the substance use disorder issue and the jail's no longer being filled with people that are hopefully going to go into recovery and no longer be jailed for some of the behaviors that they're exhibiting, but helping them understand that arrests are important, but you can't arrest your way out of the problem. We need to do all of these other things, and then hopefully we'll see what you want to see as far as the arrests are concerned. So there's a lot of work.
Yeah, no, that's very helpful because just this morning, like as soon as I was signing on to this, I got an email from one of our county FCS agents who is working, her county jail is being held up as the shining example within the state of implementing programs within the county jail to address more, you know, like literacy, recovery, like all these different issues, because that's just not been done at the county jail level in our state. And she's like, they're looking at recidivism and rearrest rates, but that's it. And they're asking my help to come up with some more things that we can measure.
I can give you one. If you can get, because people are coming out of law enforcement, you can get them as they're going into treatment programs to allow reporting back from the treatment program of how long they stay there. And one of the measures, we always say relapse is part of recovery. So we never measure relapses. What we measure is dropping out from a treatment program. Because if you're in treatment and you relapse, they don't kick you out. They just double down. Now, at some point, they will kick you out. But the first, like one relapse every here and there, they just double down on your treatment. They don't kick you out. So you want to look at how many people stay in treatment. 30 days, 60 days, 90 days. And you can even go out as far as 18 months if you want, because that's a true measure of entering long-term recovery. So one of the really cool measures you could propose to use is how long do people stay in treatment once they're released from jail if they're connected to a program.
Mm-hmm. Okay, yeah, no, that's something definitely. And I think she was a little bit shocked that all they were looking at was arrests, rearresting, and she's like, no, we can come up with something to give them.
How many people are employed within 30 days of release? That's another measure of success. Because if you've got someone who's been incarcerated and they're out and they have a job, now they're less likely to engage in those behaviors to get rearrested.
Mm-hmm. Okay, well, I'll probably send you both an email, just touch base and ask a couple more questions, because I think that they're realizing extension can be a helpful partner for them from the facilitation standpoint, and then of course of all the programming that they offer. So they're starting to knock on our door a lot.
That's a good thing, right?
Yeah, no, it's a good thing. And for this FCS agent, they're realizing that everything that they're doing can impact the people in their community through this alternative way that they hadn't thought about before. So
cool.
Thank you.
Nicole, it is 12:12.
All right.
And I just want to thank everyone I'm not on the board any longer, but as a longtime NACDEP member, it just warms my heart that in spite of a pandemic, we're still able to come together as a group. I just noticed that we have 267 people. That this is the largest conference we've ever held. 267 is huge. So happy that so many people decided to register and join the conference. There's a great slate of presentations and opportunities to meet members over the next few days and just take advantage of every opportunity that you have. I want to thank Aaron and Wiley for joining us today, and Jill. We've kind of become a family at this point. We've spent so much time together. I feel like I've spent more time with them than I have my own family over the last 7 months. And just thank you to Nicole. Nicole, I've learned a lot from you and really appreciate your expertise and your willingness to share your expertise with NACDEP, which we hold our national association very close to our hearts, and we welcome you as a new member, if you will, to our ranks.
Thanks, Michael. It's been great working with you too.
All right, with that, we'll see all your smiling faces at all the other events that are going on over the next couple days.